Good day. I am Sherilyn Francis with the Georgia Health Information Technology Extension Center. The future of health IT is here. Turn it on. At Georgia-HITEC, we invite you to connect with us at www.ga-hitec.org and via social media at Georgia-HITEC. Georgia-HITEC is Georgia's only federal and state-endorsed expert to assist providers in the achievement of meaningful use of EHR technology, and we are located at the Morehouse School of Medicine National Center for Primary Care. Today's webinar is brought to you by a collaboration between Georgia-HITEC and the Georgia chapter of the Healthcare Information Management and Systems Society, Georgia HIMSS, which provides statewide leadership for the advancement and management of healthcare information and technology. Georgia HIMSS is dedicated to improving healthcare IT locally through advocacy, collaboration, and education. Additionally, they focus on ensuring quality patient care throughout the state of Georgia. And now a few housekeeping measures. As participants, your microphones are muted and shall remain muted through the duration of the webinar. We ask that you check your internet connection for optimal video and audio. We ask that you refer all tech issues to the tech support chat pod, and we ask that you refer all presenter questions to the presenter Q&A pod. There will be periodic stopping points for question and answer, and there will be time designated at the conclusion of the webinar for question and answer. I now present to you today's webinar entitled MIPS. It's about quality, presented by Dr. Adrienne Mims, Vice President, Chief Medical Officer, and Medicare Quality Improvement Specialist, Alliant Quality. Dr. Mims has no financial or other relationships with manufacturers of any commercial service disclosed in this educational activity. The objectives for today's webinar are to evaluate how your experience with the current value-based payment programs will prepare you for the future change under MACRA, to determine the reasons that insurers are moving from cost-based reimbursement to value-based reimbursement, to evaluate the finalized MACRA rule, and to explore ways to successfully participate in the 2017 Physician Quality Payment Program. And now, Dr. Mims.
Thank you very much. I appreciate the opportunity to participate with your audience today. I hope that this is going to be a useful information for all of you who are on the line. And as she mentioned, I do serve as the Vice President, Chief Medical Officer, but my background is in family medicine and geriatrics, and also in quality. I spent many years in quality improvement at Kaiser Permanente. So this role that I've evolved into for my career is blending quality for Medicare patients in an outpatient environment is well suited, and I hope that the information I provide today is very helpful for you. We're going to talk about the MACRA, which is also called the Quality Payment Program. You may have already known that MACRA stands for the Medicare and CHIP Reauthorization Act, the law that was passed to eliminate the sustainable growth rate. The important part about this is that CMS is now evolving the way they are paying more than 600,000 eligible clinicians through this effort. We are serving 55 million patients under Medicare, and it's important that we look at a way of paying for value as opposed to just paying for costs. This step that we'll be talking about today with MACRA is the beginning. We do anticipate that there will be further evolution to the Quality Payment Program, also known as MACRA, but going forward, we'd like to really refer to it as the Quality Payment Program. So let's start so I'll know who is on the line, and I'd like for you to answer this polling question. I'm hoping that the poll will show up on the right-hand side of your screen. And it's helpful for me to know whether or not you or you're representing a practice that's currently billing Medicare fee-for-service. That means this would be very relevant for you. As you see here, great, I see you all joining this at this time. So as we see more and more of you who are saying that you do bill Medicare fee-for-service or you represent Medicare fee-for-service, this is so relevant to you. And I see that some may retire in less than 5 years. I understand that too. It's a big change. And when we look at in Georgia, 60% of the practicing clinicians are over the age of 50. Yes, over the age of 50, 50. That means that many people will be retiring in 10 years. And so if I were to do the same poll later, then we'd see a higher number. So those of you who said yes to current fee-for-service billing, this is very, very relevant for you. And if you said no, I'm sure you'll get a lot out of this presentation anyway. So MACRA, also known as the Quality Payment Program, is divided into two areas. And hopefully from this discussion, you'll see the importance of quality in these. So there's the Advanced Alternative Payment Model, which is not just an ACO, but an ACO that is being more robust in the way that it is taking risks and also coordinating care. But most clinicians are going to fit in the Merit-Based Incentive Program, or MIPS. We think that some 80 to 90% are going to be fitting within the MIPS system. So let's tell you more about that. We said that there were 600,000 clinicians that are impacted by Medicare fee-for-service. 500,000 will be part of MIPS, most of them. My conversation is truly about Medicare fee-for-service. It is not about Medicare Advantage. I just want to reiterate that. This is about Medicare fee-for-service. It is not about Medicare Advantage, but yet it still impacts the majority of those who are billing Medicare. Most people will be in the system where they'll be reporting data in 2017 to see the impact in 2019. The initial adjustment will be 4% plus or minus. But if you compare to the what we call legacy programs that are going away or being renamed as we go into MIPS, in 2019, the penalty would have been 9%. So the efforts of the initial launch of MIPS with the adjustment in 2019, the maximum will be 4%. Compared to the legacy program maximum of 9%. But it'll only start at 4%. It will grow successfully over time. So it's important to still participate and be aware of this. So some of you have seen the distribution of the performance for MIPS when it came out with the final rule. And this pie chart at that time also had a category for costs that is no longer there. 60% of this is quality, which we're going to really focus in primarily on today. 60%. So you got to do this. So what do you need to do? Most people will get a reprieve from PQRS because it's only 6 measures. You know, as you're preparing now for PQRS for 2016, that it's 9 measures. And I will cover that in the latter part of my conversation, because in order to be successful in the quality payment program in the quality area, you can practice now by participating in PQRS. So as an individual, it's 6 measures. As a group, it's 15 measures. If you're part of an alternative payment model in any fashion of shared savings, you're already collecting quality measures, and they are reporting quality measures on you, and so that will count. Regardless of the specialty that you represent, there are quality measures for you. We have plenty. Look at that. It's 271 to choose from. So it's enough for everybody to be able to participate. And when you look at this slide here, I took a list of most of the specialty measure categories. And as I was doing this presentation just yesterday, a person in the audience says, well, I'm pain management. Well, even pain management can fit into one of these categories. So most specialists will have a measure set already pre-selected for them. Many of the measure sets are far more than 6 measures, so you can choose among those 6 of which you'd like to present. Some of the measure sets may be only 4 measures, and that will count if you do that measure set of 4 measures. So how do you report? It depends on whether you're reporting as an individual or as a group, but the ways of reporting probably look very familiar to you because these are the ways that you've already had in place to report PQRS. In one of the audiences that I've been presenting, a gentleman said, well, will CMS be ready for this when it launches? And my answer is yes, because you can see here, we're using the current reporting mechanisms that are already in existence and that you're already familiar with. A qualified registry through the electronic health record, a clinical data registry, or through claims. Some people still are reporting through claims. It's important to note that claims did not go away for the individual reporting. Now, groups have to identify that they are a group and make that known and define themselves to CMS by June of 2017. And as they do, that group has multiple mechanisms that they can report. They also have the opportunity to report individually. So let's say we have a multi-specialty group of 60 physicians representing several different specialties. If they decide to, by June, report together, they need 15 measures for the entire group. One of those will be the CAPS measure, the survey of the patient experience. Now, if they look up and it's past that time, and we're in August or September, and they did not declare themselves as a group, instead they would have to report individually for all of the clinicians. Report as a group. So quality, we said, is 60%. You can get points on each measure, but if you don't submit a measure, you get 0 points. If you are participating at all in any measure, you will automatically get 3 points. And that 3 points for participation means you do not get the negative payment penalty. So it's important to know if you've already participated in PQRS in the past, it's easy for you to avoid the penalty the first year of the quality payment program, because you can submit at least one measure, and that will count for 3 points, which will help you avoid the penalty. Now, you won't get any positive payment adjustment for 3 points, but you avoid the negative 4%. So I have another polling question, because it's helpful for me to understand in the audience who is participating on the phone, so I know how to help you. And I'd like to know if you have submitted PQRS successfully in the prior years. There's one thing to submit. There's another thing to submit successfully. So over the last couple of weeks, people have been getting letters letting them know whether they have submitted successfully or whether they will be expecting a negative payment adjustment for next year. And thank you. I see on the poll that many of you have previously submitted. Some have not. But by the end of this talk, when I get to the PQRS reporting, you will be empowered of how to do this. And those who are saying, what is this? You will know by the end of the talk what it is and being able to do this PQRS reporting. That's Physician Quality Reporting System. So those of you who said yes, you have submitted before, you have available to you a feedback report. This feedback report gives you information. You also have the tool of your health plan HITEC report that gives you quality information about how you compare to your peers. And if you are a specialist who have been participating in a clinical data registry from your specialty, you see how you compare to your peers on a state, local, and national level on quality measures that are very relevant to your specialty. So those reports on quality give you a good idea of what you're doing now and how you can move forward in quality. So let's look at some examples. The first one is the PQRS report. This is an actual report from a practice that I've been working with. They report it by a registry and by claims. When you get your report, it is multiple pages of an Excel file that will list the group feedback and then every individual NPI who reported under that. They will also have a table that shows you the different reporting mechanisms. So what I'm showing you now is the page that is the reporting measures that they did through a registry. I've hidden some columns that are out to the right, but basically you could see, and I'm not endorsing this particular registry, but there's the vendor name in this column and the measure group that they chose to do. Those represent certain measures, as you see listed there, and more detail about those measures here. This was actually a primary care practice, but they did enough work with patients with COPD that they had to at least have 20 patients that they saw in a year, that they felt that this measure set would work well for them too. So if you see some of the things on here, spirometry for COPD, whether or not they're using appropriate inhaled medicines, did they get the pneumonia vaccine, reviewed medications, a flu shot, and tobacco, even though you might think that this would be appropriate for pulmonary, it's very appropriate for primary care and maybe even other specialties. So don't feel that you're limited to one particular measure group based on your specialty. What you see here is that they had to have for a registry, and that is the same going forward. For a registry, you had to have a minimum of 20 patients with that diagnosis of charts that you were going to pull. So they had at least 20 that they were able to use. So that's why it's 100% reporting rate. You see a little variation on their performance. So when you look at an advanced care plan for patients with COPD, out of their 20 patients, they only got a 70% performance rate. But they did very well with spirometry and these other measures. So this particular report is very valuable for this practice to see how quality is standing up based on what they reported for PQRS. It also shows that they were successful in reporting these measures. So if you previously reported PQRS, you would like to go online and pull your PQRS report and see what CMS has to say about your success with reporting. Now this should look familiar to you. If it doesn't, someone in your office is getting this. This is an example of a report card on quality that is prepared by XYZ insurer. They have quality measures that they are reporting to the federal government, or how they report HITEC quality measures for their private pay patients. And they look at you for those patients that you're taking care of theirs and compare this quality report card against your peers. This particular one happens to be a Medicare Advantage. But let me show you how to look at this report card about quality and what you can glean from it. Number one, these red are not good, but you probably figured that. But let's look at a particular measure, let's say controlling blood pressure. They're saying that controlling blood pressure, that this practice had 25 patients on that insurer's panel that they were taking care of, and that of those 25 patients, according to their records, none of them had blood pressure control. As this practice went further and did chart audits, they found out maybe they did have 2. But this gives them feedback that they need to know to go and contact that 25 patients, get them in, and get their blood pressure controlled. So just like with the PQRS measure for the practice that I showed you here, where they need to work more on advanced care planning because they were not at 100%, and that may have been their goal. With this particular practice, from this HITEC report card that insurers are sending to the practices on a quarterly basis, you can look at quality here and determine where you want to enhance the work that you're doing. As I mentioned before, your registry can do that also. So a new area within the quality payment program is improvement activities. These were part of the proposed rule and have moved forward to the final rule. These improvement activities are something that you would do within your scope of practice to improve the way you do work. You have to do this for 90 days straight. And those of us in the quality improvement field know that that's the amount of time that you can do a good job in testing a few theories, such as trying to improve your blood pressure control on those patients for the group we just saw. So first they can say, oh, we're doing 0 out of 35. And what we would like to do in this improvement activity is at least get to 10 out of 35. So first we would need to call them and have them come in and adjust their medicines. That would be its initial improvement activity. They test it out, get the patients in, and see if that made a difference. If it didn't make a difference, they would test something else out. Maybe we need to order blood pressure monitors for patients to do and do telephone follow-up 2 weeks later to see if that's controlling their blood pressure. You would test that out and see if that made a difference. If that didn't get you to the number that you wanted, maybe you can test out having drop-in nurse visits where people can get their blood pressure checked with no copay. So what you have the opportunity to do is improvement activities to try to improve that quality measure. The way that you will report it is through attestation, yes or no, that you did it. Now, if you're doing it, you do have to have documentation in your facility that it was done. Right now, there isn't mention of audits, but if there were an audit, it would be important that you had the documentation to show it. As you see here, there are multiple mechanisms available to do that type of reporting. If you are a patient-centered medical home, PCMH, that is accredited by Joint Commission, NCQA, URAC, any of those groups, you automatically get full credit for the improvement activity. In fact, if you do that and have full credit for the improvement activity and attest to that, that avoids the 4% penalty if you do that one thing alone. If you don't do any improvement activity, you have 0 points that would go toward the total score. So let me see who's on the phone here, again with a polling question. I'd like to know if you already are certified as a patient-centered medical home. Now, if you had done so in the past, that doesn't actually give you credit for 2017 unless you have maintained or are currently certified for at least 90 days during the calendar year of 2017. And I see that most of you are not part of a patient-centered medical home. And I understand that because some people have felt that I'm not sure how this is going to benefit me, or maybe I'm not primary care. But there is a version of medical home that is for specialists, so it's something to consider. When we look at patient-centered medical home, they generally meet 4 of the 7 requirements. And as you read these, they make a lot of sense. It truly is a home. They have a primary care clinician who is in contact with the other physicians that see their patient. They are providing good access to the patients. They're involving their caregiver and the patient in shared decision making. And they are looking at patient risk and determining who needs which service. So this is a little bit of evolution of the basic face-to-face fee-for-service model. And they get full credit for doing this. However, everyone else has to choose improvement activities. 4, if you're a large practice or in an urban area. 2, if you're a rural practice or a small practice, you may be only able to have to submit 2. I have pulled on this list here some that really apply to primary care that one could consider. There are 93 possible ones that you can consider, and they do span the spectrum of practically every specialty. But I describe how an improvement activity would go, that you would understand where you are at baseline and use a team approach to successfully go through planning, then implementing, evaluating how you did, and then trying to improve again. Now, the ones that are listed in here in red are ones that we as the Quality Improvement Organization are providing free technical assistance with. And so if any of these are in particular interest of you, our contact information is at the end of the program. I'll give you an example with the depression screening. As a geriatrician, I know that patients who are seniors, they don't come in saying, I'm depressed. Rather, when they come in, they say, I have a headache. The next month, they'll say, my back is hurting. And then they may call a little bit later and say that I'm confused about these medications. Or they'll come and want a referral or get some tests done. That's a person who is probably depressed. And so the way we find out about them is doing yearly depression screening. This is recommended as an evidence-based guideline by the U.S. Task Force for Preventive Services. In addition to that, Medicare pays for yearly screening for depression. So we as a quality improvement organization can provide technical assistance to practices who want to learn how to embed depression screening in their workflow and bill for it. You don't have to be depressed in order to get credit for the screening. So that's improvement activities. These are a sample of the 93 that are available, and those in red, you get credit by working with us as a quality improvement organization. One in particular that was on this list, let me go back for a second, is antibiotic stewardship. And antibiotic stewardship is a new one that we are providing support for. We have realized that antibiotics saves lives, we know that, but we tend to overuse them. And this new focus that we're doing is using the right antibiotic, not the big guns, but a more focused one. at the right time, a true bacterial infection and not viruses, and that's especially important now that we're going into the cold and flu season. At the right time and the right duration. I'm in the over 50 crowd, and in our training, almost every dose of course of antibiotics was 10 days or 14 days. Well, they're much shorter now. But since we've been prescribing longer big gun antibiotics, patients get well pretty quickly and they stop taking them, and the pills are on the shelf. Well, later on, when they get sick, they pull them out and use them again, or they share them with family members. That helps to build antibiotic resistance. And unfortunately, there are over 23,000 people a year who are dying from antibiotic resistance. This is not just a hospital or nursing home issue. It is an outpatient issue too. So if you are in a primary care physician practice or a federally qualified health center or represent emergency room physicians, we would like to work with you on an antibiotic stewardship program, and that will count as an improvement activity for MACRA. I mentioned depression screening, as I described. Using the screening of a PHQ-2 or a PHQ-9, screening for either depression or alcohol use counts as an improvement activity, and we can provide that free support. So let's see where we are by now. MACRA. Are you exempt because you're a low volume provider? Are you in an ACO? Are you in an advanced APM? Are you going to get credit because you're small and rural, and so you don't have to do as many improvement activities? Are you already set up to do a clinical data registry? You've worked with them last year and you're planning to work with them again. Have you looked at the feedback reports that CMS has already made available for you? We discussed the PQRS one just now. But there's also a quality resource use report that looks at your costs compared to your peers. And if you've not looked at your QRUR report, you want to. Anyone who has billed fee-for-service Medicare, you have a QRUR report on the website that you can go and download and review. It shows what your costs are compared to your peers, and certain metrics of that cost will be relevant for MACRA. Not the first year. They will be measuring them, but they won't use it to qualify you until the following year. I've shown you some improvement activities. Which of those already you're considering working on? What about your electronic health record? You actually need to be on one, but if you're not on an electronic health record, for the first year you can still avoid the penalty because you can satisfy by doing either one improvement activity or submitting at least one quality measure. So let's shift to PQRS. We mentioned it's important for the quality payment program because quality is also known as the legacy PQRS. Where we are right now, in November of 2016, it is not too late to submit PQRS measures. And so let's go over what you would need to do in order to do this. Now, this website that is listed here is a very important one, and it'll be shown again at the end. This has all the resources to help you get ready for this. Who is eligible for PQRS reporting for 2016? You see the list here. Now, it's everybody. It's not just any type of physician or doctor of medicine, like podiatry and chiropractor and optometry. Yes, all of them. But now we added the other practitioners and the other therapists, all of them have to do PQRS reporting for 2016. Yes, I know that's a shock that the list has grown over the years. Yes, it has. But all of these are considered eligible clinicians under your tax ID number. And so you may want to determine how many are under your tax ID number. So as I go forward, I'm first going to talk about reporting as an individual practitioner or individual clinician. As we go to the quality payment program, we've changed the term eligible practitioner to eligible clinician. Or are you reporting as a group? Previously, the size of your group mattered as to when the certain levels of penalty came in, but now it's uniform that everyone is rolled into the group. So the first step is to pull up your tax ID number and determine, are really you the only one billing, or are sometimes your nurse practitioner or PA or others billing under your tax ID? So if you are the individual, look at your different reporting options. You'll need to select 9 measures. And unlike MACRA quality, where you only have to have done them for 90 days, right now we're talking about 2016 PQRS. The reporting period is the entire year of claims. The entire year is the reporting period. You have multiple ways that you can report. And this link here gives you a list of those different who has to report and the measures, but it is for the entire 2016 year. If you do report, you avoid the 2% negative payment adjustment. If you do report, it will satisfy the quality measures that you would need to report for Medicare incentive program and avoid potentially that penalty if you satisfy the other requirements. Many of you may not be aware of the other penalty called the value modifier penalty. This is looking at costs, and it may be up, down, or neutral, but it is automatically calculated based on your costs of care for those patients that you see and whether or not you reported PQRS. So if you did not report PQRS, not only do you get the negative 2% here, but you will get the negative 2% or more for this particular penalty. If you do not report all of the measures, either through claims or registry, that you need to do as an individual, because you have to report 9 measures. If you don't report 9 measures and they're not in the 3 different domains, what Medicare will do is determine, should you have? And the process is called the Measure Applicability Validation, or the MAV. What they do is look at all of your claims for the entire year, for all of the patients, and they look at the measures that you submitted. Let's say you submitted 7 measures. When they look through all the claims of the patients that you see, they may determine, oh, well, you did see patients who fit under these other 3 or 4 or 5 measures. You could have submitted them. And so you will be considered as non-successfully reporting PQRS if you did not report the right number of measures, and you could have actually reported the full 9 under 3 categories. Now let's turn to groups, and I'll spend a little time on groups because they come in various fashions. So as an individual, you do want to know, did you assign all of your billing to a group who's doing your billing? And is that group reporting for you and registering with you as a group for the purposes of PQRS reporting? So just because they're doing your billing as a group, you have to ask the question, are you reporting the PQRS measures for me or not? That would be important for you to know. Now, they can report by various mechanisms, as you see here, and these are listing those that are primarily through an electronic health record, a direct interface through CMS, or again, they can use a different clinical registry for the group. Now, as a group, there are still 9 measures, and it doesn't matter what size group that you are. You can report them electronically or through a qualified clinical data registry. There are many of these QCDRs that are out here. They are vendors, and they do charge a fee. Sometimes the fee is per clinician that is reporting, and some is by measure. There is a host of them that are listed on the CMS website, and you can look among them and the different measures that they are able to report to determine which one you may consider working with if you have not already been doing reporting thus far this year. And remember, it's 9 measures across 3 domains that is required. And as a group, you also have to do a CAPS measure. A CAPS is a survey of the patient experience with your care. Your group may already have the ability to do web interface. Let's say you're a hospital-based group that has multiple practices and multiple specialties, and you're all on the same EHR. So they have the data for you, and they may be doing a direct submission through a web interface, such as through Epic or an Athena, for instance. Other options, by doing the group interface or doing the data registry, it avoids the penalty. Again, that's a major reason for doing it. So if you don't satisfactorily report, or if they underreport, or they don't have the 9 measures, then you are subject to the 2%. If they do report and they're not successful, you do avoid the value modifier potentially, but you have to at least report the PQRS measures. Maybe you're in an ACO. There are many accountable care organizations available across our state. Some are for private insurance, and some of them are Medicare, the Medicare Shared Savings Program. There is a variety of them that currently exist, and I'll talk a little bit about them. But if you're participating with them under their tax ID number, you can avoid the penalty because they will be doing the reporting for you of quality measures. But don't just assume it. You do want to ask, and that does allow you to avoid the negative payment penalty. So first, as an ACO, you want to determine, have I assigned my tax billing to them, and are they doing all the measures because we're on one electronic health record and they're doing it through the GPro web interface. If they're doing it that way, it is still a 12-month reporting period. So they really won't actually submit till about January, because you want to make sure you've gotten credit for every patient you've seen through the entire year. Those more advanced ACOs who have been in the business for a couple of years have been successful in saving money for both them and the government and improving quality. They have applied to become either a pioneer or a next-gen or next-generation ACO. Participating in one of them avoids the payment penalty and satisfies the EHR incentive program. So it's good to know if your ACO that you're participating in is in a pioneer or next generation ACO. If you are, then they are going to be reporting for you, usually through a web interface, reporting the entire year. Okay, so we've come to another polling question. We're toward the end now. Really need to know what you're thinking. So with this polling question, from the information that I've given you, do you feel that you can now go forward to start doing what you need to do PQRS reporting? And I see that some are saying, I need some help. Well, we as the Quality Improvement Organization are here as help. We are free help. And if we didn't give you quite enough information today, I do have some resources for you. I see that nearly 70% of you are ready to go forth and be successful with PQRS reporting for this year, which will put you in good position for avoiding the penalty as you do the same thing next year in 2017. So this is a website that you need for PQRS reporting. All of those who said, help! This is a wonderful CMS website. And I point you to the implementation guide and this whole toolkit. This, if you scroll, you'd scroll very, very far down because it has a step-by-step instruction. You can even print this out as a PDF and see screenshots for each one of the pages that you would need to do for PQRS reporting. It's a wealth of resources right there, and I'd urge you to consider using these resources to help you in your practice. I see someone on here said no, they're not going to do PQRS reporting. I hope that you're the person who also said that you're retiring within 5 years. So where do you go for help? 3 things I'd like for you to know about, in addition to the website I just showed you that is directly with CMS. Number 1, in preparation for MACRA, or the Quality Performance Program, they have an outstanding website, the qpp.cms.gov. I was surprised when I went on it that this was really a CMS website. My goodness, it looks like someone in their 20s or 30s created it. It's easy to navigate, it's intuitive, it is a wonderful website. I'd urge you to go through it and walk through and get a lot of your questions answered. Maybe you've joined the Transforming Clinical Practice Initiative. They are funded, well funded by CMS to provide hands-on technical assistance to help you evolve your practice and get ready for the Quality Payment Program. They are still in open recruitment. There are several available now in our state. And if you go to this website, you can see which ones are available for you. Last is the Quality Improvement Program. And I'll leave my website email on the next slide. But if you're in a different state, this is the one that you would look at to consider where you would need to go for that support. So we will go forward now with some questions. Do we have any questions available for now? Let's see here. From Kim White, what reporting year are providers currently receiving letters about if they did not participate in PQRS? Excellent question. Right now you're getting a letter that is telling you what to expect for next year in payment 2017. That letter is reflecting your PQRS performance for 2015. So it's a 2-year look back of the penalty versus the payment. So people are receiving now letters about PQRS payment adjustments that will happen in 2017 based on what they did in 2016. You can't do anything to correct that. That's just the way it is. You can, however, look at the PQRS report that is now online. And if you think that there is an error in there and that you really did report and you thought you reported successfully, you want to look at your report. We are now in a period of time where you can request an informal review before those penalties start. The informal review period was 60 days long, but we're toward the end of it. It ends the end of November. So if you've received one of those letters and you think that there is an error, then it's important that you look online at your PQRS website, look at your report, and see what happened. So thank you for that question. Do we have another question?
Yes, thank you, Dr. Mims. As Dr. Mims indicated, we are open for Q&A, so if you have any questions, please feel free to submit them in the presenter Q&A pod. So our next question is the MIPS track easier to start than the the APM track?
Yes, the Advanced Alternative Care track, you would already know if you're participating in an ACO like a Pioneer or a NextGen, and only those groups will be able to be considered as an advanced alternative payment model. Somewhere in the language, there was a listing of medical home, and people thought that if they were a patient-centered medical home, they could be considered as an APM. That is not correct. It's only those advanced ACOs for Medicare who are accepting some level of risk will qualify as an advanced APM. Now, let's say you are in them. Well, then it depends on if you are seeing enough of your Medicare patients within them. If you don't have a minimum of 25% of your Medicare patients involved with that APM, or 25% of all of your Medicare billing is part of that APM, then you're still subject to MIPS. Great question. Do you have another question?
Yes. Can our practice use our present EHR functionality for reporting PQRS to report data for MIPS?
Possibly. So when you go to the qpp.cms.gov website, it'll walk you through reporting. And it has a website that links to ONC. There's a specific website that you can go on and determine if your particular EHR and its version is able to do the direct reporting as an EHR. You do want to see that. Because if yours is not at the level of certification, 2014 certification or 2015, then you are not going to be able to directly report that way. So excellent question. There is a website on ONC that you can use to check that. Next question.
Thank you. What are some strategies physicians can use to manage the quality factors outside of a physician's control?
Well, there's always the concern about the patient who is not getting better. And they may not be getting better for a variety of reasons that are either socioeconomic or patient preference. When you think about that, that occurs universally across the country. It is not limited to one physician's practice. And so when we're looking at quality measures, we're never expecting to be 100% because patients will do what they do. And understanding that that patient characteristic that may be a challenge is universal among physician practices around the nation. So what you want to do is, rather than considering that a patient may be, that old term we used to use, non-compliant, think that they may be really non-adherent. Maybe they can't afford the medicine, or maybe they ran out. Or maybe they're having a side effect to the medication, or having a problem that they're considering a side effect. Or maybe they're cutting them in half and spacing them out, or thinking they can't take it that day because they were going to go partying that night. So as we talk to the patient and uncover what their adherence barriers are, sometimes we're able to overcome them. And the more we are doing that in our practice compared to our peers, it'll allow us to have more patients able to be controlled compared to our peers and have a higher quality score. But understand, everybody does have those challenges. Thank you. Other question?
We have another question, yes. Is the MIPS track easier to start than the APM track?
Okay, we did that one. We did that question. Did you have another one?
We sure do. Sorry. So we have a question regarding the PQRS website. What is the website for PQRS reporting? Excuse me.
So when you go on this website, this toolkit, and you scroll down, it'll link you to that exact website to do the PQRS reporting. I would recommend going through this website because it's not very simple to go online and do PQRS reporting. You first have to set up an EIDM account, an Enterprise Identity Data Management account. And once you have that account, that allows you to do your reporting and go and see your prior feedback reports. It is a multi-step process to be able to log into those websites. And some people have been significantly challenged with that. So we as the QIO at Alliant Quality, we are hosting webinars practically weekly on this. My colleague Donna Cohen is hosting those. And I'd ask that we post that information into the chat box so that everybody will have access to that, because there is one of them that she is going to be doing even today as of 1 o'clock. Thank you. 1:30, excuse me.
Thank you so much, Dr. Mims, and we have now reached the conclusion of our webinar. It is now 1 p.m. And we thank all those who registered for today's event via Georgia HIMSS or via Georgia-HITEC, and we thank each of you for attending, and this slide does contain Dr. Mims' contact information. Additionally, the webinar recording and presentation will be made available to all those who registered. Additionally, these are some resources. Again, the presentation will be made available to all those who registered. Again, we invite you to participate in Part 2 of the Privacy and Security Workshop. The workshop takes place on Friday, December 9th from 9 a.m. to 2:30 p.m. and the registration deadline is November 28th. Additionally, we invite you to participate in the Georgia-HITEC Health IT Educational Needs Survey. You can access all of the announcements by clicking on the slides and selecting the link. Dr. Mims, we thank you for an informative presentation, and we thank each of the participants for attending today's presentation. Again, this was a collaboration between Georgia-HITEC and Georgia HIMSS, and we thank you. You can access the presentation at www.ga-hitec.org and connect with us via social media at Georgia-HITEC. And we thank you for your attendance.